Our next patient for live demonstration is 63-year-old male having 63-year-old male having history of dyslipidemia, presented with anterior wall MI with severe LV dysfunction. His primary angioplasty to LAD has been done. RCA is showing critical lesion in the proximal part, and our plan is to do robotic assisted PCI to RCA.
Dr. Sanjay, you're on.
Yes, okay. So just I'm showing the robotic preparation. This is a robotic arm. Here, okay, you can.
Okay. So the CorePath GRX system consists of two parts: the interventional cockpit and console, and the bedside unit, which consists of the extended reach arm, the robotic drive with bedside monitor, and the disposable cassette. The robotic drive that they're attaching the cassette to now is what translates the movements that the physician does at the cockpit into what happens to the wire, guide, and balloon or stent.
Okay.
At this point in time, they've attached it. They close it.
So here,
and the system performs a cassette test. The bedside monitor tells the person at the table, step by step, what to do. At this point, they're moving the robotic drive towards the guide. If you look closely, between the co-pilot and the guide, there is a drive gear, a white gear. That allows the physician to torque the guide during the procedure.
yes. Okay. So here where we fix the guide, little more. And this is a sleeve which will slide over the guiding catheter and make it fixed. Okay.
So that
now we'll load it with PTCR and PTC balloon. You can say.
So the guide support track that slides over the guide and connects to the sheath, that's what allows you to move your guide forward and back without the guide kinking. At this point in time, they're loading the wire.
You can grasp wire with this so that it will not move.
It saves time to pre-select a pre-dill balloon and load that.
Tudu lidus. So very tightly, is it? Tazuna.
So within the cassette, there is a linear drive and a rotational drive. The linear drives are what the balloon stent fits between. They're wheels that when the cassette closes, the wheels close around the hypotube of the cannula of the balloon stent and move it forward or back. The wire has a linear drive and a rotational
PTC
drive.
balloon is over here. Yes.
The rotational drive to the back is what allows you to torque the wire.
So this is, loading is complete.
At this point in time, Dr. Patel is ready to enable and start the procedure.
Enable all. Yeah. You can come here. Come.
Go there.
Sanjay, I am supposed to cannulate, right?
No. Already cannulated.
Cannulate, okay.
Semilusoria.
Semilusoria. Please be seated. Please be seated. Yeah, Sanjay told it is pseudo-arterial lusoria. So he cannulated. Otherwise, I could have shown this cannulation. Anyways, guide catheter engagement is done. I am locking the guide catheter. And now, millimeter to millimeter, I am going in with my wire, scout. It's a tough lesion, huh? Scout. Okay. Millimeter to millimeter. I am not in hurry. Yeah. Now I will rotate it. Scout. There is another lesion there. And the direction of the wire is perfect. No. Scout, it is going in small branch. So now I will be rotating a little bit and pushing it. Okay, Scout, it's going in a small branch, so I will come back. I will be rotating it only in one direction and I am through. Scout, oh, it's going in some branch again. Scout, no. Scout, Sanjay, is it okay? No. Scout,
Yes, okay.
It's a tough lesion, huh?
You can slide balloon.
I can take advantage of the balloon now. This is a turbo. I press turbo button.
Guiding is out.
Now, Scout,
Guiding.
Scout, guide is out. I will unlock it.
Little
Huh?
pull on guide.
Yeah.
Scout.
Scout.
Yes. Okay.
I will now clockwise rotate it and go in with the guide. Scout.
Origin is little awkward at here.
Okay, no problem.
Dr. Patel, so,
Because-
I'm really glad that this is happening because I think this is one of the potential advantages of the new system here. But if we're doing this manually, typically it's a sort of a to and fro between pulling the balloon back, advancing the guide. So
I mean,
how does that
Scout?
work here with this?
Okay.
Are we able to?
Direct.
Pardon?
So I was just pointing out that if we weren't using the robot here and we were
Pull.
losing guide position, we would be pulling the balloon
Fifty.
back, manipulating that guide. But with this system
Fifty.
now, we have better guide control.
Yeah.
But does it work in concert with the balloon in terms of pulling the balloon back? Can you do that simultaneously?
Yeah, I can use all these three knobs simultaneously. But I took a while. There was a learning curve for me
Little more.
to be used to it.
Okay.
And to be comfortable with this, for this particular hand-eye coordination.
Reflect.
Record, come down. You want to check it, Sanjay?
Yes.
Record. Looks good?
Yes. Looks good.
So, one long stand.
Proximal, one more dilatation.
Okay, yeah.
Okay.
Okay.
18.
15, come down. Okay, I use turbo to remove balloon. It goes very fast. Okay.
Tejas, Rajiv here. This is a fantastic demonstration.
Thank you,
And
Rajiv.
we're really excited about seeing the future.
Injection.
Well, I have just a quick comment and question. First of all, maybe you could tell us how the patients from yesterday have done. Have they done okay?
Yeah. You mean to say the robo cases?
No, all patients.
All
Just the
patients.
audience wants to know that.
Yeah,
Patients.
two of them had some forearm hematoma, which was dealt with a BP cuff technique, and none of them had any problem. God has been kind to us. Said
That is great news
Yeah.
to hear. My second is really a comment, and I speak for, I think, everyone in the audience to say your team is second to none. What an amazing team you have.
I
Please,
take it
send
as
them out
compliment,
there.
and let me tell you once again that it is not me. Tejas Patel is Tejas Patel plus Sanjay Shah is equal to Tejas Patel alone. That's it. So he has always stood by me Even Rajani is with me since so many years, and all my colleagues and all my staff. In the cath lab staff, you see, Yash mainly. I must give credit to Yash Soni, who has always been with us for every single new things. Never say no type of attitude. And I have been a blessed person to have all of them with me.
Yeah, you're a very lucky person, and congratulations again.
Thank you.
And,
I take it as compliment.
And I would also like to endorse that as well, and just want to be sure that everyone had enough rest last night. There were some challenging cases.
Absolutely. One of my colleagues slept in the hospital because we wanted to make sure that if any problem happens, we don't have to run. So one of my colleague, was here in the hospital in the room. So any problem, he was always available. So we make sure. Even tonight, somebody will be there.
And it's always important to make sure that everyone in the team is getting enough rest and praise. I just want to be sure that the robot got enough rest last night as well.
Stand.
Thank you. Stand. Tell me, Sanjay, what we take?
3.5, 38?
38. 3.5, right? Okay. We take 3.5 by 38 synergy. But Rajiv and Malcolm, we are at Apex, me and Sanjay, along with others, we are looking forward to having some sort of association and collaboration with you guys in Mayo Clinic for robotic cases and the studies and all those.
We would be sincerely honored to
I am the distant student of Mayo Clinic. Both of you know that. A student of Mayo Clinic without degree.
Well, there's more students in the Tejas Patel University here than I've ever seen. So. Tejas, let me ask you about the robot. If you could have one recommendation for the next generation, what would it be in terms of an upgrade or a modification?
Yeah, I want it to be a versatile instrument which even a new guy can use. It means that with hands, this knob should give you comfort of your pair of hands. The day it happens, you are done. One-to-one torque for every situation, guide wire backup, guide catheter backup, movement of balloon, the stent, everything. You can do coordinate with your hands. Similarly, you should be able to work with these knobs with equal efficiency. Then we are done. And let me tell you, I was asked that why you chose to work with Robo. It is too new. But Rajiv, in year 98, 99, I used to have dreams of radial. At that time, radial was new and not so popular. But I used to have dreams of radial, and with the help of Dr. Saito, we converted into a very stable radial program, an educational program. And those dreams never came until last year when I started dreaming of Robo. So out of just my inner instinct, I have bought it and I have started working on it. And I am sure that this dream again, works the way it worked for my radial program.
The explanation we got from your Corindus colleague there in the room was very nice, very eloquent, and showed how the setup worked. It was very good. I don't know whether or not they can share with us already what sort of additional improvements can we expect to see in the next version of this.
They need to still work, for us it is no problem, but they need to work for less experienced guys, and for that they need to work on the guide catheter and guide wire significantly.
So one thing we can't do is rotational atherectomy. I don't think we can do OCT. I'm not sure we can do IVUS.
All those things are to be incorporated. There is an auxiliary track in the cassette, and through that you can do, but that part you have to do manually. But there is a possibility of putting 2 wires, and 2 balloons, but that is through the auxiliary track. But it should be inbuilt, yeah, that should be the new generation. Yeah.
So one question, you're one of the pioneers in starting this robotic technique, doing patients. So if someone wants to do this, which stage of his career would you advise him to move into it? Very early in the career while he or she is learning the preliminary PCI procedures simultaneously with that, or once that person is very at ease with the procedures, doing them manually, then shift to this?
With this generation, I will say that, the guy, whosoever wants to indulge into it, should have experience of 400 to 500 interventions independently. Then it means that a person is a seasoned operator. But I want to see the generation where even I can recommend a guy who has done 20-30 angioplasties and who can work on this.
So I think that my perspective here would be that if you have this device in your lab, that your fellows should be using this almost from the beginning if this is going to be the technology of the future.
That's right.
And don't forget, your fellows are probably going to be better at operating this than you are, well, certainly me, because they've grown up playing video games, and they're going to be much more facile than any of us older folk.
That's right. So this is turbo. I am going very fast. Now I am going slow. And I am there. Record. Sanjay, we go a little further.
Yes, little more.
Millimeter by millimeter.
Okay.
Scout. Little back.
Little back.
1 millimeter. Scout. If it is short, we have to go through the stent and deploy another stent. And that can be shown, no problem.
It's perfect.
Record.
It's perfect.
Looks good? Go.
A little more?
Little more.
Little
Okay.
more. 2 millimeter more. Sorry.
Now.
Oh, yes. Fine.
Okay. Go. Only 11, 12 over here. Maybe go up 14, 15.
Tejas,
Yes.
with that very proximal ectatic segment, any chance that we could see OCT of this at the end?
We can push it through the auxiliary track. Yeah, we can see that. Let's see. But that will not be through the robotic arm. We can pull back. Sanjay?
Yes.
I will pull my guide a little back, and then the catheter, a little back guide. Okay?
Yes,
Yeah.
it has come.
Go.
Okay.
Go.
We can post
18, maybe 20. Come down.
20. Okay. Now we assess the result. If needed, we can dilate with 4. Proximal part particularly.
Wait, now I will push my guide in. Simultaneously I will pull my balloon back. Okay?
Okay.
That was very nice, yes.
Now
Record.
take shoot. Oh.
Malcolm, tell me what you want me to do, OCT, or it's okay?
There is a tissue prolapse.
Or
Proximal
this is
part.
tissue prolapse. This is tissue prolapse. Or you want me to dilate with a non-compliant balloon, the proximal part.
Well, first of all, I think you need to do what
4
you feel
millimeter.
most comfortable.
Yes, 4
I think
millimeter.
it would be very interesting just to see the OCT, to see that tissue prolapse. It would be...
Okay, but you want me to dilate first with a 4 millimeter balloon?
I think that seems a reasonable idea. Let's post dilate
Yes.
and then have a look
Yeah.
with OCT.
So now,
4 by
okay,
short. 4 by short.
4 by whatever, 12 or a non-compliant balloon, maybe NC track or quantum maverick. Non-compliant, sir?
So one other improvement in this might be, so we see here that the cassette's been opened up here and manually pulling all this out.
Yes.
Wouldn't it be nice if this could all just be done automatically all the way so that
Absolutely.
no hands have to be put on this?
Absolutely. That will be the day, actually, yeah.
And maybe we can have custom-made robots, like that robot has a memory of what Dr. Tejas Patel does, right? And sort of does that.
Malcolm has a different opinion on that. Last night only he discussed. You know, whenever Malcolm and Rajiv, whenever I get frustrated in some case with robo, I always think that when angioplasty evolved, the cardiologists must be getting frustrated using the regular, you know, those old balloons and using those bulky stuff and not getting successful. But ultimately, there is a transition, and now you have the greatest instruments available. So someday, we are hoping that we will have similar situation with this.
I think that's a really good point, and it's an opportunity to say it's great that there are so many fellows in the audience here, and we've met some of those, and they should realize that the pioneers of angioplasty, without them struggling, we would not be here today.
Yes. Okay.
Okay. Guiding.
Okay.
Bus. Okay, wait a sec.
Even just the development of
15?
stents, just change everything. I can remember those evenings at 6 o'clock, 7 o'clock, 8 o'clock, using perfusion balloons trying to tack down the sections.
Yes.
And these procedures would go on for 2-3 hours or more. You have to get up and go to the toilet in the middle of it. It was
little more proximal.
Huh?
Little more proximal.
Little more proximal. You want me to come now? In that case, I will be working simultaneously with my guide and balloon both.
Okay. Okay.
Go.
Push balloon.
Okay.
Okay. Fine. Go. 20. 20.
Come down.
Okay. Deflect.
Sanjay,
yes.
Are you ready with the auxiliary track, or you want to show OCT off robo?
No, we are ready. No issue.
Okay, good. Sanjay never says no. At least never says no to me. Can you check it, Sanjay?
Yes.
Record. It looks nice. So we do good. OCT or turbo. This is turbo.
Tejas, Rajiv just pointed out to me that it's very unusual to see tissue prolapse like this just disappear.
Yes.
So I think it's going to be really interesting to see on OCT what exactly has happened.
That's right. Professor Akasaka is here, so he will be giving commentary.
and I think it would be
sidetrack. We introduce from here only.
Yes.
Yeah. It's sometimes we can identify by angio, but still there are only a few tissue by OCT. So I'm not sure the true mechanism, but in the higher pressure, bigger balloon, we reduce the amount of tissue prolapse within a lumen. So you can confirm in this case what really happened by OCT.
So could we see that tissue prolapse that's gone downstream?
No. Just the wall attached to the beneath to the stent, right?
So Tejas, could we just stop here for a moment? Can you just show us this auxiliary track here?
No.
And just explain exactly what's happening for the audience.
Okay.
Sanjay, why don't you show the audience?
I will show.
Auxiliary track.
So here, just I will show by putting this balloon so that you can better understand. This is a track for balloon normally, but at the parallel there is this track. This cannot be maneuvered by robot. This we have to maneuver manually. This is maneuvered by robot. So this is auxiliary track. At present, this balloon is in auxiliary track.
You can.
But still the wire and the guide are still going to be locked in place, correct?
Yes, yes. So it will be locked here. Okay. You focus on this.
Show us the OCD.
Only OCD part. So
Yes, so maybe our AV people here, we got this, we got the picture-in-picture of the
Okay, you don't
the
need
X-ray.
a lumen profile.
Can we remove that image in the bottom left-hand corner where we're seeing the still frame?
Yeah. Now.
Is it okay? I just
Well, it's fine, I guess.
Longitudinal view and yes. So right, and the automatical movement. I try from distal, okay? Review, right? Here is a distal edge. Some tissue prolapse, right? Here and here, right? Okay. And yes, our position is very wonderful, right? But slightly, the symmetricity is sometimes not completely symmetric because of the plaque, yeah. And many of you are very concerned about the proximal side.
Yes, this is
here
proximal.
is a tissue prolapse, right?
Yes.
Yeah. And here is just proximal, a wonderful position.
Excellent.
Right? Again, I try to move slightly the cursor. Only one strut is here, but almost all strut attached to the lumen. Right?
Professor Akasaka, can you redirect our attention to that tissue prolapse?
Yes, here, right? Some tissue prolapse around the 12 to 3 o'clock, right?
Yes.
And here also 1 to 3 o'clock, some tissue prolapse, right? Here is some crack, right? But other side, no tissue, some crack I can identify.
So what do you think the mechanism was? It angiographically we could see the tissue prolapse, then it disappeared. Is it just being pushed back through the struts? And what is going to be the natural history? So if you were to do OCT in 6 months' time, what are we going to see?
Yeah, after 6 months we can identify the very smooth endothelialization. This will disappear. And the problem is if you try to do the ACS cases, there are a lot of thrombs. We don't know, we cannot predict the future condition of the big thrombs within a stent because the thrombs may organize or may disappear sometimes. So it depends on the condition of the DAPT or anticoagulant condition. So, but tissue will disappear, and we don't mind if there are. But generally speaking, in case with stable angina, tissue prolapse is only a small amount, and the final result after 6 months or 8 months, the condition will be very wonderful. Any question or comment? This is a real proximal site. Some node can be identified, right? Okay, but a position is very wonderful.
So, you know, if if I could be permitted, I think that this is really a comment for the young cardiologists in the audience.
Yes.
And I think it's an opportunity to pay credit and homage to the Japanese for their contributions to interventional cardiology over the years.
Thank you.
Because I can remember the very first angioscopic studies. You were talking about thrombus.
I see.
And this came from the Japanese and looking at the fact that you could still identify thrombus 6 or 8 weeks in after PTCA and in stents following ACS.
Yes, yes.
Their contribution to CTO, I mean, which is just really unparalleled. Also to left main interventions and the use of smaller catheters, OCT here as we see, and I'm probably forgetting some other things, but I think that for those people just coming into the field, just to recognize those contributions over the last 30 to 40 years. And also, as someone reminded me yesterday, actually it was you, Professor Akasaka, when we first met on Friday evening, that the first bioresorbable stent or resorbable stent was the Tamai stent, Hideo Tamai's stent from Japan, long before the BVS.
Yes.
So again, I just wanted to just take that opportunity to, I think, educate our younger cardiologists and appreciate your expertise here because it's really been phenomenal.
Thank you very much.